Welcome back to GME Compass. I'm Julie Galano, and I'm the co-founder of GME Compass. Today, we're going to talk about something that impacts graduate medical education. It's something that many people never stop to intentionally analyze. In fact, it's something that most people at all levels in education leadership don't entirely understand. And that is, what type of residency program structure are you actually working in? Because not all residency programs are built the same. In fact, as program coordinators and program managers, we often say our programs are so unique. No two programs are built the same. No two programs function the same. The leadership styles, the reporting structures, how it's actually set up, access to faculty admin time, how reimbursement is affected within the institutional system. Some programs are university-based, some are community, and some are hybrid between the two. And then we're also going to talk about the operation side of a program. So do you operate with centralized oversight, or are you highly decentralized? And understanding the differences between these structures can completely change how you approach your workflow, your communication, compliance, quality and patient safety operations and processes, leadership, and even your burnout as a program coordinator and program manager. So before we jump in, just a quick disclaimer. We have no financial disclosures. Everything that we discuss today comes from our own experiences in working across the GME continuum in different institutional structures and environments throughout our careers. This presentation reflects our personal experiences and perspectives, and it is not representative of any current organization or roles that we may hold or have held. And then, of course, our learning objectives. So by the end of this video, the goal is that you're going to understand the major residency and fellowship program structures. You're going to be able to identify the operational differences between them and recognize some of the risks and some of the benefits with each model. None of them have all benefits, all pros, or all cons. It really is finding a balance between them in how they're operationalized and what function makes the most sense. And honestly, my hope is that this also helps you better understand why certain things in your own institution feel harder than they should, or different from another program when you talk to a colleague of yours. This topic matters so much more than people even begin to realize. Program structure impacts oversight, communication, coordinator workload, the resident experience, the clinical learning experience, the patient experience, as I had said before, quality and patient safety, decision-making, as well as ultimately accreditation risks. Thing that I've seen repeatedly in graduate medical education is programs often struggle, not because the people are bad at their jobs, but because the expectations don't align with the structure that they're operating within. And that is the expectations of the people and the expectations of the role. And we talk a lot about job descriptions as well. When those things don't align, that's when there starts to be operations breakdowns. So for example, a decentralized program might expect university level standardization without university level infrastructure. This is something oftentimes when you hear me speak about my own experience and some of my own frustrations and my own wishes, or it would have been better if, is probably if I had to identify one bullet point or one sentence that really got to the crux of my burnout, it was probably this sentence. There was a lot of little contributing factors that kind of wore me down, but this ultimately is the systems issue that to my biggest pinch point. Another example is a centralized institution may unintentionally slow down program innovation because too many approvals are required. There's a lot of layers to a centralized oversight. So understanding that structure helps explain the why behind your operational pain points. And that's important to understand when you're reflecting and you're thinking about your job and you're thinking about your role and your own growth and opportunities for you to take your role to a higher level or to a different area of expertise. If there's something within your program that you really want to master or learn or develop, how these things operationalize at a systems-wide level, at a kind of an organizational structure level, so that you can understand your whys first before you start to assess. So today we're going to break down 5 major concepts: university-based programs, community-based programs, hybrid. Sometimes you will also hear them called communiversity programs, which was what I had come from, and also operationally your centralized structures and your decentralized structures. Something important to remember is that these categories can overlap. So a program can be community-based and centralized, or university-based and decentralized in culture. So don't think that these are very cookie cutter, rigid boxes that your program needs to fit into a specific one of these. It can be a combination. So let's break these down one by one because each one operates very differently behind the scenes. When people think of traditional academic medicine, this is what they're usually picturing, is a university-based program. So university-based programs are directly affiliated with medical schools or large academic medical centers. They're often tertiary hospital systems with highly specialized services and high acuity patient populations. Characteristics of a university-based program usually include things such as strong research infrastructure, subspecialty exposure, large faculty. We talk a lot about faculty admin time, faculty time for teaching, faculty time for scholarly activity, different academic opportunities. They also often have a strong emphasis on scholarly activity. These programs are ideal for residents that are pursuing academic medicine, research, or highly competitive fellowships as their next steps. Benefits are huge. They're very significant. They're very resource rich. They often have funding from various different areas, various different outlets. They have access to large simulation centers, a research team and research staff. They have not only grant opportunities, but they also often have a grants team to help you and guide you through those processes. However, that being said, there's no one of these types of programs that are absolutely perfect. So there can be barriers. Residents often have less early autonomy. You have less early access to cases, less hands-on access to cases early in your residency or your fellowship. Decision-making can move extremely slowly, making it feel bureaucratic. The bureaucracy can sometimes create operational frustration for both the trainees as well as the program coordinators and the program managers. Another challenge is balancing research expectations with the clinical training demands. When you're a resident or a fellow, you are there to learn in the clinical learning environment. That being said, university-based programs are heavy on research and scholarly activity. So sometimes those demands and those requirements can compete against each other. Some residents thrive in that. That's what they love. That is what fills their cups. Those are the things that really make them get joy in their residency and fellowship experience. However, others might feel overwhelmed. It's not for everyone. Now let's shift over to a community-based program. These are generally sponsored by community hospitals, regional systems, or outpatient-focused organizations. So these programs often are very, very clinically strong. Residents tend to get a very high procedure volume, often early on in their residency or their fellowship training. They get hands-on experiences, and they have early autonomy to their patient care. Honestly, many community-trained physicians become exceptionally confident clinical physicians because they are immersed in practical medicine right from the jump. So as I had mentioned, the benefits and the strength of a community hospital are community connection, hands-on learning, and the practical early clinical exposure. Barriers can be extremely challenging. You have very limited research infrastructure. Not only do you have limited research infrastructure, but you also have limited resources. I had mentioned at a university-based program, there might be a team to help you through the IRB approvals, through that process. If it is a research project through IRB, getting them through those processes, community-based programs won't have those teams that might fall on the resident, the fellow, or the education team to get them through that. And your program coordinator being the base and the crux of that program is going to feel a lot of that operational challenge. Also, the funding with those things, not only as in the people and the teams, but funding and access to research and grants and other types of innovative experience and learning tools, as well as support for faculty to participate in those things. Because in community-based hospital systems and programs, a lot of times the faculty are seeing patients, all of that hands-on clinical learning, that's where your faculty are. So they have a harder time getting compensation or admin time or something in order to support them participating in those things, along with the trainees to support them in their learning experience. So I think that it's probably important to say less academic doesn't necessarily mean lower quality. It just means that the focus and the structure are very, very different. Hybrid, the sweet spot in between the two of them. So a hybrid program is where my experience has come from. We were a community hospital that was affiliated with a university. So as I had mentioned earlier, they're sometimes called communiversity programs. And honestly, they're one of the most interesting and dynamic models within graduate medical education. These programs that blend community and university environments together to make a swirl ice cream cone. So the characteristics, you might have a community hospital with a university affiliation, as I had said. Shared faculty, might have shared rotations depending on the infrastructure, the location of that relationship, the opportunities amongst the different affiliated hospitals, as well as academic oversight. So many residents and fellows really love these programs because they feel like the best of both worlds. They're very rich in culture, gaining little pieces and little nuggets from both of those spaces and bringing them together to create a hybrid. So these programs often provide strong mentorship, excellent procedural opportunities, as well as academic support. However, you are going to have barriers. You're going to have financial and infrastructure barriers because at the end of the day, it still truly is a community hospital, but you're going to have access to some of the resources that you wouldn't in a traditional community model. Hybrid models can be extremely complicated. Sometimes they can be pretty muddy. You're often balancing community expectations along with academic expectations, research requirements, and varying institutional cultures. So I sometimes describe hybrid programs as managing from the middle. We talk about being a program coordinator or program manager, that we often lead from the middle. A hybrid program is the same. You live in this middle ground where you're not really one and you're not really the other. And hybrid programs often struggle the most with consistency and standardization. And I would say that this probably does hold accurate from my personal experience. One of the challenges that I found was, for me personally, I was in a hybrid institution and we were a decentralized model. And I would say that these pros, these cons, these pinch points, as well as these benefits and the strong culture, strong mentorship, strong relationship is pretty accurate to my experience personally. So now we're going to shift from program type to operational structure. So what does that mean? So centralized models can mean that the graduate medical education office handles and oversees most operations across programs. So that might include things such as onboarding, policies, accreditation oversight, faculty development, compliance tracking and training. Also, something else that typically happens in a centralized model that isn't really on this characteristic slide is reporting structure, pay, not only for us as program coordinators and program managers as a universalized GME team, but the trainees as well. A lot of times those reporting and oversight structures funnel up through a central GME team. And what are some of the benefits of those? The advantages of centralized structure is consistency, standardized processes, there's standardized resources, there's standardized leadership, shared oversight, and unified support systems amongst programs, fellowships, and residents alike for the most part. This can reduce duplication and improve accreditation readiness. There are trade-offs. Centralized systems can sometimes become extremely bureaucratic, very similar to what I had mentioned in the university-based programs. They might feel like they've lost flexibility or autonomy because you have some more layers. At the end of the day, you are a program that is connected to a specific department or specialty. You have the centralized GME vision and goal and advocacy hat on, making these decisions and going through these approval processes and procedural change processes. Now, let's talk about decentralized structures. As I had mentioned, my history is from a hybrid program with decentralized reporting structure. So what that means is in a decentralized model, individual programs or departments manage majority of their own operational processes. This is common in smaller institutions, community health systems, or rural training environments. Programs of decentralized models might have a significant amount of autonomy in curriculum, scheduling, recruitment, as well as their operational workflows. And from my experience, I would say that that holds absolutely true. Each program or department, probably each department manage their own curriculum. They created their own curriculum. Our GME office, as we are getting ready for maybe site visits, or if we want to expand our complement or something to that extent, our GME office would be involved from an accreditation perspective, the annual program evaluation time. They'll look at curriculum, scheduling, workflows, and things such as that. But they're just making sure that you are meeting GMEC and ACGME expectations and requirements. The details in how it functions, your SOPs, your operational processes, all of those things are very unique from program to program, and from an outsider looking in, might look extremely different across two programs. The benefits are exactly what I was just speaking to, flexibility and autonomy, right? Programs can tailor processes to their specialty as well as their patient population. So you might have two specialties and two departments that are set up, that function, that operate on a regular way in the sense of their culture, how they see patients. Are they inpatient? Are they surgical? Are they non-surgical? They can really tailor those things to their department specific culture. However, decentralized systems can also create major inefficiencies. You may see inconsistent policies, technology fragmentation, and coordinator overload. I would say not only coordinator overload, because you end up in this kind of gray spot. I always used to say, well, of course it's coming to our team. As long as you cock your head and squint your eyes, it's education, because a resident or a fellow is involved. And you can argue that almost any interaction within a department is a teaching experience. When you're in a teaching hospital, that teaching is so deeply ingrained in your culture. So that can come down to, you can kind of lose sight because the department's vision, goal, mission, and ultimate metrics are very different than a pipeline that's focused on education. And then ultimately, kind of the all that ends up in the middle is the program coordinator and the program manager. So that can really feed into coordinator overload. I would also argue different departments sometimes might have more access to benefits, not benefits in the HR sense, benefits in terms of wellness activities, food trucks, catering opportunities, access to additional funding for conferences, maybe additional kind of slush funding for things other departments might not have. So that can even result in resentment in the trainees and even the coordinators, because sometimes your coordinators then are your middle person that have to explain the whys, but it's not a very easy, cut and dry, straightforward why. So one thing that I've personally seen happen in a decentralized environment is kind of this idea that everyone is accountable, therefore no one is accountable. Everyone is accountable until something kind of becomes a problem, and then it's a game of not it. So it's a game of, well, you don't report to me from your GME, but then at the same time, your department might be saying, well, we can only control so much over education, or it's up to X, Y, and Z, or it's this person in education that has to make the decision, even though education says, but you don't report up to us. So without clear ownership structures, things can very easily fall through the cracks. All of these things that I'm saying that are opportunities for improvement from my experience, that being said, I really do think that it is kind of the perfect sweet spot between the two models. It's very fragile, and you have to be very aware and very cognizant of how fragile this model is to make sure that you are systemically setting it up in a way that's sustainable and can be successful, especially in the accreditation space. So when we compare those models side by side, you really can start to see the operational trade-offs. So university and centralized systems tend to have high resources, high oversight, but low flexibility. Community and decentralized systems often have high flexibility, but they're potentially a higher operational risk. Hybrid systems, they can vary dramatically depending on leadership alignment and institutional culture because of exactly what I was saying. So this directly impacts us, the program coordinators and the program managers. It affects who makes the decisions, how the communication flows, how quickly issues get resolved, how much responsibility sits within the individual teams. So take a moment and pause and think about your model. Think about your institution and what does your institution actually operate under? Maybe more importantly, think about, does your leadership expectations actually align with the structure that your institution is? So one of the biggest mistakes that institutions make is assuming that all programs function the same way. And when I say institutions on this slide, I mean the operational people who tend to not have graduate medical education experience make your budgeting decisions. They make your FTE and team decisions. I feel like I could say this in each and every presentation in a different, more specific way. We are a very niche environment. We are a niche profession. So that is why I say one of the biggest mistakes that institutions make is assuming all programs function the same. They don't. When leadership expectations don't align with operational structure, it creates risk. So another major issue is overloading your coordinators in a decentralized environment without providing adequate infrastructure or support. And this is what I was speaking to earlier. So hybrid programs often struggle when there's no clear ownership of the processes and the procedures of which they or their team are responsible for. Like I said earlier, there's no perfect model. Every structure has strengths. Every structure has risks. The key is understanding the model that you are operating within. Where are the gaps in your program and your institution? And how do you, as a leader within graduate medical education, intentionally build systems around those realities so that you can start to improve your training environment? So again, thank you so much for joining us for this conversation. I hope that this helped to clarify the evolving landscape of graduate medical education administration and leadership. If this topic resonated with you, please comment below. Let us know, what do you think is the biggest challenge that is facing GME professionals right now, especially in the organizational strategy space? If you found value in this discussion, please like our video, subscribe to GME Compass on YouTube. You can follow us on our socials and check out our digital download resources. We have plenty of toolkits that are designed specifically for GME professionals to make your everyday workflows more efficient and streamlined. Again, thank you for being here, and we'll see you in the next video.